Основная задача у современной медицины — придумать, как в кохлеарных имплантах сделать слух еще лучше, речь разборчивой, музыку музыкальней. У них есть одна концепция — это более точная стимуляция слухового нерва. По каждому участку как можно более точно. На самом деле нерв происходит не стимуляция нерва, а стимуляция мозга. И примеры показывают, что предстволно-мозговой имплантация стимулируется не в улитке, а у ствола мозга. И там точно стимуляция вообще невозможна никак по участкам. И наука как бы этот факт не замечает. Несмотря на то, что люди, которым дали стволо-мозговую имплантацию, слышат, понимают речь, слушают музыку, и все окружающие звуки они слышат точно так же. И я записал небольшой подкаст современный. Вот недавно был этот подкаст, интервью представителя науки. И он рассказывает, как они решили сделать стимуляцию более точной и, значит, слух более качественным. Послушаем его. Вот. Сейчас. Вот. Например.
Med-El podcasts are for educational purposes only. Not all medical devices, surgical techniques, or indications discussed are approved in all countries. Please always follow the approved labeling and surgical information for your market. Please contact your local Med-El representative for queries on the status of regulatory approval in your market.
Welcome to another episode of the Med-El podcast series on closest to natural hearing. I'm Peter Knopp, and I'm one of the directors in R&D at Med-El headquarters in Innsbruck. Today we're talking about individualized cochlear implants, and joining me today for discussing that topic are Professor Greet Mertens and Dr. Masoud Zoka Asadi. Professor Mertens is the Auditory Implant Research Program Coordinator at the University Clinic of Antwerp. Welcome, Greet.
Hi, good morning, Peter.
And Dr. Asadi is the head of image-guided surgery and surgical tools, also working at R&D at Med-El headquarters in Innsbruck. Welcome, Masoud.
Hello, Peter. It's great to be here.
As I said, we'll talk about individualized cochlear implantation today. That is cochlear implantation that is tailored to an individual patient's cochlear anatomy. We'll start with the basics first, and then talk about technical, clinical, and performance aspects of individualized cochlear implantation. And I'll start with Professor Mertens. Greet, as a quick refresher of our anatomy classes, as an introduction, could you briefly explain what is meant by the tonotopic organization of the human ear?
Absolutely. Maybe I'll start with some more simplified terms. You can compare the concept of tonotopy a little bit to the organization of the keys of a piano, for example, where low notes sit at one end of the piano keyboard and higher notes at the other end. And so this kind of spatial representation of the notes or of the frequencies is also present within our auditory system. The hair cells there at the base of the basilar membrane, they are responsible for the higher frequency sounds, while the hair cells at the more apical parts, they are responsible for processing the lower frequencies. That's because of the typical physical characteristics of our basilar membrane, because we know that the basilar membrane is very thin and wide at the apical side and much thicker, more narrow at the basal side. So as a result, a low frequency tone like 20 Hz, for example, maximally stimulates the membrane near the apical end, while a higher frequency, also let's say 15,000 Hz, maximally stimulates the membrane at the basal end. So human tonotopy, it's a complex, but I think a wonderful process that allows normal hearing listeners to perceive the really entire spectrum of sound.
Okay, so tonotopy is really a fundamental principle of the cochlea. Do cochlear implants also make use of the tonotopy of the human cochlea?
Great question. As the CI actually takes over the role of these damaged hair cells. And there the answer to your question is yes. A cochlear implant also mimics this natural tonotopy of the cochlea so that it can also provide this kind of pitch information, this pitch perception to our CI recipients. And maybe again, in simple terms, low frequency sounds are sent to the electrode contacts in the apex of the cochlea, while the higher frequency sounds are sent to those located more basally. That's a general idea, but here I also want to highlight that our cochlea is incredibly unique. It's a little bit like a fingerprint. So some of us have a very, very large cochlea with a long cochlear duct length, while others sometimes have a very short cochlear duct length. And there, the tonotopy in these very large cochleas, of course, follow the same basal apical gradient as in small cochleas. But as you can imagine, the large cochleas, they have a more spread out tonotopic frequency scale.
That's an important aspect. So you're saying that the cochlea is something like a personal characteristic, like the fingerprint for an individual. And that size can vary considerably between individual cochleas. Does this lead to different requirements between different patients as to cochlear implantation? Considering that the one user or the one candidate has a long cochlea and the other one has a shorter cochlea?
Yes, indeed, that's correct. Because, for example, when the same electrode array is used, let's say a Flex 28 electrode array, in someone with a relatively long cochlear duct length, this results in a smaller angular insertion depth compared to someone with a shorter cochlear duct length. So if we then apply the default CI frequency allocations in those two patients, the mapping will match the natural tonotopy more closely for one person than for the other.
So you're saying the electrode can either be too long or too short if you really aren't picking the most appropriate electrode for a candidate. Does this have consequences on outcomes?
We asked ourselves the same question. And therefore, we conducted a retrospective analysis on data from our CI patients, implanted all with a flexible 28 electrode array to be able to answer this question. So in a first step, we calculated the so-called frequency to place mismatch for each patient. So that's the mismatch between the default frequency allocation of the CI and the actual tonotopic frequency of the cochlear neurons. And then we analyzed whether this frequency to place mismatch influenced the speech perception scores that we always measure at 6 and at 12 months after implantation. And indeed, we found that the smaller the mismatch observed, the better the speech perception outcomes at 6 months. And this correlation disappeared 12 months after cochlear implantation. So we suspect there that the brain is, in some patients, capable to compensate for this measured mismatch. However, the brain plasticity will not be equally adaptable in everyone, I think. And then I'm thinking, for example, of older adults. So we should try to keep this frequency shift as small as possible in order to ensure an optimal start in all of our CI patients, I think.
That's really interesting. It all sounds very logical, but it's also a challenge. So what's the solution now, right? So you have a candidate in front of you. You don't really know how long that candidate's cochlea is. You don't know what electrode to pick. So how are you dealing with that problem?
Yes, that's true. And so what we are doing as part of our standard daily clinical practice is that before implantation, based on a preoperative CT scan, we calculate the individual cochlear duct length using the Otoplan software in all of our patients. And then we select the appropriate electrode length that is expected to cover at least around 600 degrees in order to minimize this frequency to place mismatch that we were mentioning earlier.
So you're saying you have a tool at hand that lets you measure cochlear length and pick the most suitable electrode. And that tool is called Otoplan. Right. Masoud, I know that the Otoplan tool is coming from your factory, so to speak. Can you briefly explain how this tool really works and what it does and how it helps people like Greet to really individualize cochlear implantation for a certain candidate?
Sure, Peter. Just to add to what Grit already mentioned, so the Otoplan supports the clinical team before and after surgery. And before the surgery, the goal is to help the clinicians to choose the most suitable electrode for that specific patient. So before surgery, the clinician uploads the patient's CT or MRI images. Otoplan creates a patient-specific 3D reconstruction of the key temporal bone structures like the inner ear and the cochlea. And based on this 3D visualization, clinicians can virtually plan the electrode insertion and select the most suitable electrode and surgical approach for the patient.
Okay, so that was a very quick rush through Otoplan and the procedure. Can you explain in a bit more detail how anatomy-based electrode selection works and how it differs from traditional approaches?
So traditionally, the electrode length was chosen based on a general preference or on a one-size-fits-most approach. Anatomy-based electrode selection with Otoplan, on the other hand, is different because it starts with patient's anatomy. First, the software, the Otoplan, creates a 3D reconstruction of the cochlea, including the scala tympani, and provides automatic measurements of the key cochlear parameters. What is the cochlear diameter, what is the cochlear width, and what is the length of the cochlea. Additionally, you can also add the patient's audiological information to the planning, and then the software combines this audiological and anatomical information to help you to compare different electrode arrays within the specific cochlea. So you can see the predicted insertion depth, the predicted frequency coverage, and whether the scala tympani is big enough to accommodate that selected electrode. And using all this information, one can select the most suitable electrode array that best matches both the anatomical and audiological needs of the patient rather than relying on a generic solution.
But coming back to that general solution, why is cochlear length so important when choosing the optimal electrode? I would think if you have an electrode that fits all, that would make the procedure much more simple.
That's a very important question, Peter. It really gets to the core of why Medal has developed such a broad electrode portfolio over the years. The main reason, as Grit mentioned, is that the cochlea size varies considerably between individuals. So if you use the same electrode in two different patients, it can end up covering very different regions of the cochlea. So if an electrode is too long for a patient's anatomy, it may not fully insert. Some electrode contacts may remain outside, and the effective stimulation range can be reduced, potentially compromising the hearing outcomes. On the other hand, if the electrode length is too short for the anatomy, you have apical and low frequency coverage can be limited, which increases the frequency mismatch and can negatively affect the speech understanding and perception, as shown by several studies like the ones of Anthem. And this is why we emphasize and we mention a lot to use the preoperative planning and electrode selection with Otoplan, so one can really choose the electrode length that is tailored to the patient's anatomy with the goal of achieving the maximum cochlear coverage and hearing outcome.
Now, it seems that that's really an important step in the cochlear implantation procedure as a whole, but it also makes that procedure a bit more complicated. You know, if you don't have to do Otoplan and you just use the one-size-fits-all electrode, it just removes one step of complexity. Now, considering that, what kind of feedback have you received from surgeons using Otoplan and audiologists using Otoplan in clinical settings?
The software was introduced in 2018, and by now, as also mentioned by Chris, it's been adopted by many clinics worldwide and is being used as part of the clinical routine. The main or most common feedback that we hear is that this 3D visualization and surgical planning gives clinicians at least more confidence before going into the surgery, knowing they have selected the most suitable electrode length for the patients. And many clinicians appreciate being able to compare different electrode options within the same cochlea and to use this 3D visualization to discuss the plan with the surgical team and when appropriate, even with patients and their families. And to make this planning and electrode selection even easier, over the last few years, there have been many developments to have more automated pipelines and having also ability to plan on different image modalities to make this planning easier and more accessible and faster. So it can be integrated within the clinical routine much better.
So that adds a bit of complexity, but also it adds safety in a sense, right? So the surgeon isn't really blind anymore as to whether the electrode that he has in hands really will fit into that cochlea or not, right?
Correct. It adds more confidence to the procedure and it ultimately increases the quality of the procedure.
Right. That's really interesting. Great. Do you discuss these individualized approaches with CIS candidates and their families pre-operatively? Is that something that candidates do want to know about and then really appreciate what they hear?
Yes, for sure. And the latest versions of Otoplan, they are very visually attractive, I think, very user-friendly as well. So that's why we increasingly use it